Good morning. I'll call the Kennewick County Human Services Committee meeting to order. Thank you all for being here. Again, it's good to see a lot of faces in the room and a full dais up here, so it's starting to feel normal again. So first order of business today is the approval of the minutes. You received those in your packet. I'd entertain a motion for approval.
I will make that motion.
Commissioner Nissen,
I'll second.
motions. Commissioner Gardner seconds. Any discussion? Hearing none, all in favor signify by saying aye.
Aye.
Opposed, same sign. Motion carries. We also have bills to pay. You received those as well.
I'll move payment of the bills.
Commissioner Gardner moves on the bills. Do I hear a second?
I'll second it.
Commissioner Anderson seconds. Any discussion? Hearing none, all in favor signify by saying aye.
Aye.
Opposed, same sign. Motion carries. We had one warrant to cancel. I'd look for a motion to cancel that warrant. Commissioner Berg moves to
I'll second that.
cancel. Commissioner Nissen seconds. Any discussion? Hearing none, all in favor signify by saying aye.
Aye.
Opposed, same sign. Motion carries. Thank you. All right. Jenny, you're going to resume the conversation about the Blue Cross Blue Shield contract.
Yes, good morning. Thank you. So I'll just do a little recap from last meeting. The Blue Cross Blue Shield Care Coordination contract has been something that we've been watching and analyzing for quite some time. It's always been the assumption that the county would continue this work as long as it's viable and it doesn't require any county levy dollars to be used to support this specific contract. These last few months, we've really started to look at this contract more closely with the upcoming changes to the Min Choices revision launch that happens this November. And then also just the continued increasing numbers of referrals that we're seeing in our other service areas, that being our Min Choices assessments and our waivered services. So again, the Blue Cross Blue Shield Care Coordination contract is not something that the county has to opt into. It is an optional contract for counties to be involved in. We have our other service lines in the home community-based area, Min Choices and waivered services. Those two areas are required that we at the county provide staff to carry out those services. So as we've been trending and seeing our numbers in our county, our mandated service areas are continuing to grow, and we're looking at needing to add staff to those mandated service areas on top of this contract that we hold that's optional, and we're looking at needing to add some staff to that as well. In turn, when we continue to add staff, we're needing to look at another layer of management, that be a supervisor to assist with these areas. So again, care coordination is where a subscriber, Blue Plus, someone's on MA, Blue Plus, those over the age of 65, receive help from a social worker or a nurse. That individual helps them with medical appointments, if they've got medical questions, if they need help getting resources. They're kind of that liaison. And right now, we at the county have been able to support our staff working on behalf of Blue Cross Blue Shield to carry that out. So again, we are at a capacity in the agency where we're looking at needing to grow. Again, not just this area, not just the contracted services area, but the mandated services areas. And so that's why we've decided that we need to take this forward to all of you to really take a look at where we want to go. Is it something that we're going to invest county dollars and continue to provide staff and increase our staffing levels so we have our current staff doing this role? Or do we look at potentially terminating this Blue Cross Blue Shield contract, and we have capacity in our other service lines to not have to lay off any of those staff if we make that decision now, and we would be able to repurpose those staff and have them in similar roles within the agency. There's a lot of unknowns coming in the future. Again, the Min Choices revision is the biggest one, and that's why we really started to look at this more closely. We've been watching this for a number of years, even back to that work session in 2018 when this contract was specifically looked at. But then more recently, because we're going to have to invest a lot of staff time and training to learn this new tool that the staff are going to be required to do as a part of their role. So we're going to invest a lot of staff time along with the additional resources of needing to ramp up our staffing levels. So I am going to open up the floor, and I'm going to have the current supervisor of the area, Tammy Goldenstein. She's been overseeing our community care coordinators for the last couple months, and she's going to give you a little bit of background about the Min-Choices revision and just some current trends that she's seeing with our staffing needs.
Excuse me, Jenny, before you leave, does anybody have any questions on what Jenny just presented? Commissioner Burke.
I guess I have several questions, but maybe they'll be answering the questions too. I could save them, if you will.
Sure.
How long have we been providing the service, first off?
Oh, Tammy probably can give.
1999 or 2000.
Okay, yeah.
Would be when the contract was signed. I don't have the contract right in front of me, but it would be right in that time frame.
That's what I thought.
Beth Nelson came out about that. I did a time overview, and that would fit right within it.
And I guess along with, and Tammy might be addressing that too, is what would the impact be on the clients? Because I'm assuming we did it, not to get the dollars, but it was a good fit at that time, and that our mission is well into the continuing services. And I'm wondering if we drop that, what the impact would be, and if you're going to address that.
Sure, I can speak a little bit to that right now. So it's not like these clients would go off of the Blue Plus program. They will still continue with their normal services that they're getting. It will just be a different face helping them with this care coordination. So it wouldn't be a staff person from the county. What's going to happen is Blue Cross Blue Shield will need to enter into another contract with a different provider. Locally, our U-Care contract is with Lutheran Social Services in town. So, I mean, this goes on in many other counties where the county doesn't provide the service. It's an outside entity that provides that service. So really, clients shouldn't see any downfall in this. It should be a hopefully seamless transition because we would be working closely with Blue Cross Blue Shield. As again, it's a 130-day notice that we have to give, and in that time there would be some transitions. And even from a provider standpoint, so providers as well, they should maintain billing the same way. There really should be no disruption to the client or our providers. It's just not going to be a Candy Ojai County staff going out and doing this work. It's going to be a different provider that they'll enter into an agreement with.
So it's not going to be an extra step for our clients to get this service. You don't have to go to another place physically, or the idea was all kind of one-shop type of stop, that they would come here and get the services, and it was more seamless. So it's still going to remain seamless, I understand.
Yes. Yep.
And another question about the reimbursement we get for that. What % do they reimburse at?
So Blue Cross Blue Shield pays every 15-minute units, and that's what they're paying right now.
Basically, that covers what % of the salary?
Yes, so right now that is covering a majority of the staff's salaries, but as we look at adding staff, adding salaries, and then adding a supervisor, that's when we come into a problem where we're going to have to tap into levy dollars. And we do need a supervisor to have oversight of this group of people. We did try to separate them out where we had community care coordinators under one supervisor and the nursing home care coordinators under another supervisor. They've been all together, but what's happening is I have supervisors right now that are overseeing 19 and 17 direct reports. So really when we look at that, there's not enough oversight. And these changes with Blue Cross Blue Shield continuing to increase, we really need someone that has that direct oversight of this specific program. Right now, our supervisors are very great at being able to oversee a lot of different service lines and a lot of different programs, but with all the changes to the waivered services areas and Min-Choices, we really need to probably look at making some structural changes, and that being for this specific
If I
area.
understand, and two of the staff will probably, what's the time period for this in?
Well, ideally, we would want a decision made so we either know that we're going to invest dollars into training these staff for the Min-Choices revision that's coming, and that comes in November. So staff would have to be starting to train on that relatively soon, and I'm sure Tammy can speak a little bit further to that.
So we are going to have to stay in the program until when?
Well, depends on when we would give notice, but if we would give notice sometime in June, then we would meet that deadline of having staff not be involved in this work by that November 1st. That's what we're hoping for.
Commissioner Gardner.
Thank you, Mr. Chair. Jenny, if we terminate the contract, we'd be repurposing our employees into other areas. Would they be doing similar or not a similar work?
Yes, so some of the staff would likely go into the min choices area. Those staff do the upfront assessments to then look if the client or subscriber receives services through the county. The other staff would then likely go into our waivered services areas, and that would be doing similar work, but they wouldn't just be serving the over 65 population. The waivered services that encompasses a large, broad range of people in that category.
And your needs in those areas are already growing.
Correct. Yep. And then we do have a couple other staff. We don't know where some of them would land, but it would be in a similar situation. We would have 130 days to work with the staff, work with Blue Cross Blue Shield to make a plan moving forward.
And in either case, the clients currently being served under this contract will be taken care of.
They will, yes. That's something that Blue Cross Blue Shield from DHS, they're mandated to do. So it would just be Blue Cross Blue Shield finding somebody else to carry out this work.
Okay, thank you.
And my question was I think you answered about the investment. Because you talked about MNsure and then you talked about investing, and I'm not sure if you were saying investing in the Blue Cross Blue Shield training or the MNsure, and I think you answered.
Yes, so these staff will have to be trained in a new tool in order to do their work because they're required to have to do this min choices. And maybe now is a good time to have Tammy come up. She can speak really eloquently
I
to
hope we didn't
this.
steal any of her thunder.
Yeah, no, she will have a lot to say about the trainings, yeah.
Let's just hold it until Tammy gets up.
So, Jenny asked me to say, from a supervisor's perspective, why are we here today? Why are we asking this question? So, again, as Corky said, I supervise this group of individuals since before the contract, when we did all of this work for elderly waiver alternative care. Then DHS made a decision in legislation to basically mandate seniors who go on MA to enroll in a managed care product. So what's really important is to know DHS and the legislature made this decision to pull these recipients away from the county and give them to Blue Cross Blue Shield, UCare, Medica, whoever signed a contract to do the Minnesota Senior Care Plus product and the MSHO product. What they did is then the primary work we did with these individuals was elderly waiver, for those who've been around for a long time, and they chose to put that into this product. They call them products. And so they said, okay, county, you will no longer be serving the seniors in your county for elderly waiver. So basically, when we started this whole process, we had staff that were doing this work. It was something new. We didn't know how it was going to turn out or work. Wayne was considering whether we do county-based purchasing or not. The counties around us were looking at that. And basically, it was a good decision to let's go in and let's start doing this and let's see how things turn out. Lots of things change in legislature, time goes on. So we've now been doing this since about 1999 to 2000. In 2018, I was taken out as a supervisor. So again, going back to the question, why are we here today? I came back in the fall of 2020, and I was really taken back by how many more care coordination duties were assigned to them. Doing electric toothbrush service agreements, supplemental benefits. These individuals were really working. That was my first impression. The next thing I dealt with was a maternity leave, extended maternity leave, then 2 resignations. Then I started to look back and realize this team has not been fully staffed until early 2019. It's had a lot of turnover, and at the same time, a lot of new demands that were coming upon them. So where we were at, as me, as a new person coming in, and the final piece to realize is now we have MnChoices revision for them to deal with. Having been the MnChoices supervisor since it started, I remember 2016 and the launch of MnChoices. It was a very difficult year. MnChoices revision is going to start that process all over again. It is a completely new tool. It has completely been reorganized. None of the data that our MnChoices assessors have put in since 2016 will be there. They will have to manually upload all of it. The same things with the care coordinators. all of their paper documents, 10, 15 years of client's assessment and information, they're going to have to manually enter. So when I look back, I said, this is really the game changer for this team. This team has been running short on staff. They've had a lot of responsibilities added to them. And now we're going to have to figure out how they're going to be able to do min choices in addition, because it's, again, mandated. An average min choices assessment initial takes 15 hours. That's when you're putting in all the data. That's a lot of time. And for this particular group of people, they don't have the same amount of time that a regular min choices assessor has to do their assessment. They have to do it within 365 days of the last assessment. So if they did it on the 10th of the month last year, they have to do it the 9th of the month before. We actually failed our audit because we didn't achieve this last time because of the staffing turnovers. When I looked at some of the issues, I think that was part of our challenges. The other piece is, besides the quantity of time, the shortened deadlines, it came to my conclusion, and I said to Jenny, we have to reorganize. We have to do something different. So based upon those factors, again, we have a difficult decision before us today. And I just believe the key thing is we can't do nothing. We do need to make a decision to move forward because the 2022 budget's here. I put together the budget with or without a contract for Carol. We have to make some decisions. If we're going to go forward with the necessary resources that I believe we need to have, we have to have those in the 2022 budget. The other thing is min choices revisions here. DHS is under contract to this organization. For everyone to know, Minutes did not do the revision. They went to an outside firm. So they have a contractual obligation to launch in 2021. It's going to happen no matter what because otherwise they have a fiscal penalty that goes with it. So we have 2 deadlines, and that's why the decision's here in June. The budget's due in June. Min Choice's launch is November 1st. We have to make our 130-day advance notice because we are in the process right now of starting the training of those staff to be able to do those min choices assessment. We will have a lot of administrative upload responsibilities that we're going to have to do between now and November 1st. And making this decision really helps with us understanding what we can do. The other piece is truthfully, there needs to be more supervisory personnel. You cannot have, if we added the resources without a supervisor, we're talking 2021 staff. It does not work that way, and this program is very different than regular min choices. They will have different components in their min choices to meet criteria than we will because of the managed care requirements are different than regular min choices. So with all that in mind, that's the reason why I came to Jenny in early, April, May, and said, I just strongly believe when I'm coming from the outside looking in, as a supervisor just starting back in this role in fall, something needs to change. So I would just encourage you, it's a tough decision either way, but I would just say to you, I don't think we can delay the process. We have to make a decision to go forward with the resources in the 2022 budget or basically make a tough decision.
Thank you.
Yeah.
Now, I'm going to open up for questions again. Corky?
Just a couple. You're talking about the budget, that was one of the questions I had. Since we're talking about 5 staff, 2 might be absorbed by retirements, am I correct? And then 3 staff would be reassigned. Now, since from a budget point of view, where do we shake out? I know you can't have those exact figures in front of you, but if these positions currently are being funded quite fully, there's certain circumstances. The other 3 staff and that they reassigned, would they be reassigned to areas that might be billable or not? And what's the effect on the budget there as well? That makes sense.
Yes and no. I'm going to say it's kind of twofold. Again, we don't know where this is all going to go. We don't know where some of these staff are going to fall in terms of the agency, if they're going to stay with us at the county. I mean, the staff would have the option to resign and hopefully continue this work, not for us, but for whoever would opt into that contract. So there's quite a few unknowns, but I will tell you that yes, there would potentially be 2 positions that likely would maybe be either absorbed in a different area or one that might be restructured like 50% of its time that would maybe not be 100% reimbursable like it is now.
The staff you're talking about, is there a combination of like case aides and social workers and nurses? Or?
No. Yes, a combination of nurses and social workers, but most of them are social workers and there is a nurse on staff as well.
So we have 3 people, salaries we don't know budget-wise where we will be asking if we do drop the program. And roughly what, and maybe if Mr. Kleindl can answer this too, what do you look at per person salary that we may have to absorb a percentage of?
Sure, and I will say that these positions that we're talking about, the 3 being absorbed, they would have to be in the budget no matter if we continue this contract or not. Because of the increasing numbers of min choices referrals that we're getting and the number of people that are going on waivered services, we would have to have those 3 positions in the budget, whether we continue this contract and repurpose those staff or continue with the contract, and then we would have to hire additional staff.
But we may not have the revenue.
Well, they do produce revenue, it's just not at the same 15-minute unit. So I would say that it's very similar. Min Choices is paid differently, and so is waivered services. And I don't know if, Carol, do you have anything specific that you'd want to add to that?
The waivers pay in 15-minute increments, like Blue Cross.
You have to come up to the mic so the
Yeah.
TV can pick it up.
So I'll introduce Carol Tollefson as our fiscal supervisor.
Good morning. So the waiver program reimburses on 15-minute increments, just like the Blues contract does, same rate, actually. And then also, the min choices is the part of the time study. We have 2 lines of revenue for the min choices people. One is a state revenue line and one is a federal revenue line. So there is a direct correlation. You can actually pull these staff out and say, this is what they bring in. And again, those 2 areas are mandated. We have to provide. This contract is not mandated.
Larry, you had a comment or question?
Well, I think we don't want to get in the weeds yet, because that's the whole purpose today is just to look at what we're going to do with the contract. The details, that's what once we know what you guys decide, one way or another, then we can work on what we're going to do with staff or not do with staff. Regarding the per diems or what they bring in, again, I'll say what I said at the last meeting. What is our mission? What is your mission here? Is your mission to provide the services to people that are in need, or is your mission to go out and chase the revenue? So we can do either one, but again, what is our mission? The clients are still getting the service. We're a subsidiary of Blue Cross Blue Shield right now. Clients are still going to get their services, and the providers will still have their same pay. It's just that it won't be funneled to Canada County Family Services. But this is your decision. What we do with our staff, we'll start that process during that 130 days. We have a good plan. We have an idea what funds that will be there, but we don't have all those facts nailed down 100%. We also do not know in 18 months, will Blue Cross Blue Shield continue to pay us in the 15-minute increments? Will that be allowed from the state to those? And if that provider then changes that billing, then what you see as a lucrative funding stream changes. Now, we don't know that. We're making decisions today based on information we've been studying for the last 18 months. And we're trying to make the best decision on the information we have. Am I saying that right, Jenny?
Yes, you're spot on.
So, Jenny, I didn't count back 130 days. This decision will have to be made by when? Is there
I would hope today, because the next board meeting would put us past the deadline, and then we would already have to start doing the launch, because we would be into that November.
and do you anticipate a reaction from Blue Cross Blue Shield to, I mean, there must be other counties in a similar type of situation as what we are, and maybe you visited some of those other counties, and can you talk about that a little bit?
Yeah, so even most recently, I just talked to our contact at Blue Cross Blue Shield as of Friday, and I was very transparent. I said, I'm going in front of the board again on Tuesday. Do you have any additional information? Is there any additional pieces that we should be looking at as an option besides continuing to add staff and administrative burden? to be able to carry out this work. And again, none of the solutions that Blue Cross Blue Shield can provide us are viable. They looked at trying to have us work with surrounding counties. I did reach out to surrounding counties. Nobody has the capacity to be able to assist, because a majority of those smaller counties do a combination of work. They do this contracted work, plus they maybe do min choices or waivered work. They have dual roles in some of those smaller counties. So that leaves us again with no options of doing anything to kind of get us by or work with Blue Cross Blue Shield so we could continue this partnership. And again, they're very aware. I just, Friday, I talked to them again. So we've been in constant communication, trying to brainstorm different avenues that we can look at, and just nothing's panning out, whether it be their software systems and they can't cap the number of referrals that come to our county, along with the different plans that people jump around on. There just wasn't anything viable.
Thank you.
My concern is that I got answered well, and that helped me quite a bit and helped me make the decision. But I think we got 5 staffs that we have revenue for them, and all of a sudden we eliminate that revenue. You know, what's going to pick that up? You know, and then you said there's other options, and that's the important thing. And I don't think it's getting into the weeds from a budget point of view. We need to know how these 5 staff are going to be funded if they're reassigned. And I think we need some direction in that and suggestions. And don't want to get in the weeds, but on the other hand, we have to be aware of the budget and the dollars. And on that level, the benefits, you'd be looking $75,000 to $100,000 a year per person, I'm guessing. So I've sitting in, but it sounds like that's going to work out if I'm on the right page. I have another question, but I'll come back to that.
I have one question then.
Okay.
Or I
Commissioner.
don't know, or maybe to clarify my understanding, I think also you guys have a need for staff in these other areas, correct?
That
And
is
so
correct.
It kind of helps solve that issue. And so,
And that's again why we wanted to bring this forward now, because as we're looking at the overall agency needs and looking at the next year's budget and allocating all of these supervisors that know the ins and outs of their units and the needs coming, we know that we have a capacity to reabsorb all of these staff and keep them. Now, is that to say if we continue with this contract down 3 months, 6 months, a year from now, that would be the same case? It's likely not, because at that time then we would inflate our staffing levels and we probably wouldn't have a need for all of them, maybe a couple, but probably not all of them, which we are in the situation right now to reassign all of this staff and not have a layoff.
okay, and then my other thing was Blue Cross Blue Shield, they haven't been real clear how it is going to be going for the future. Is that one other concern that we have, is a little bit of uncertainty on how they're going to be reimbursing us? That I'm correct on that, or am I wrong?
Yeah, I think that's always been up for discussion. I don't think, I mean, when you enter into a contract with somebody, you don't know when the contract's going to change. That's no different than if we have a contract with somebody. So I think that, yes, we've been trying to get some additional information from Blue Cross Blue Shield, and we just don't know where it's going to go. It might stay the same.
Yeah.
But there is the unknown of it could potentially change with the increasing time it's going to take.
Larry, then
I'd
Commissioner Nissen.
like to add, because I was involved in the initial negotiations. All the other managed care organizations pay on a capitation payment. We got a very special deal from Blue Cross Blue Shield to pay us by 15-minute unit. We had to work really hard to get that through. So I want you to know we are paid atypical to the norm.
Okay.
And also with case management redesign, the 15-minute unit will probably go away for all waivered services to some type of a TCM rate. Now, that's just in proposal, it's just in the legislative documentation. We have no idea what the legislature is going to do. But that in turn then would prompt, there would be no rate for us to work off of.
Okay, and TCM stands for?
Targeted case management, and it's a lump sum payment based upon a month for what a function that you do. So there is a discussion to take case management out of the waivers as a service and make it into a targeted case management role. That's been in the legislation for a long time. They still wrestle with it. So I just think as the board, for you to know, there's a lot of other things going on around. And when we got the 15-minute rate, that was kind of a unique deal only with Blue Cross Blue Shield. UCare pays by capitation.
All right, and so basically, no matter how long it takes, you might only get just a certain
Right.
amount.
That's-
And
That's why we
might be
term,
spending more time than what what you're getting
Right.
compensated for.
that's why we terminated our U-Care contract, is we lost money on the capitation model.
Larry,
You want to take Raleigh first now?
Commissioner.
Oh, I'm still fuzzy about, but are we going to have to, if we keep the people we're currently being paid for by Blue Cross Blue Shield and move them to the other areas, is that going to increase our budget because now we're going to have to pay for them?
No, we would have to have them anyways.
I know, but
Yeah,
it's like
so-
adding staff because we're now going to have to pay for them, correct?
Sure, but they do get, they are reimbursable positions, so we do get,
From state or federal funding, okay, I
Correct.
follow that, all right. You know, Corky's been in the system for years, so he's got a much better feel than,
I had the same question.
yeah. It's, if we keep the contract, then I understand that's another two-edged sword because they're gonna change all the potential pay rates, they're gonna change the actual work. Is that what I'm hearing?
so there's unknowns if they're gonna change the pay rate. We don't know that. That's something that, again, why we wanted to bring this forward. And the work is gonna change a little bit because the staff have to be doing a certified min choices assessment, and that's a whole new tool that comes in November, and that's when they have to start doing that work.
So when you say there's no viable options been offered by Blue Cross Blue Shield, that's because they're not being straightforward in telling you what they're going to pay, or?
No, I wouldn't say that that's it. I would say that, again, we were looking for a way that we could cap referrals. So we could just continue doing this work with the amount of staff that we have. We don't have to continue to increase staff and then you have to increase supervision. We asked them to do something like that. And they don't have that capacity to do that. And again, Tammy started those conversations early on and then I got involved as well. So we really started with that concept. Is there a way that you can limit the number of referrals? We'll continue to do this, but not do it at the increasing rates that we're seeing, because they aren't dropping off, they're continuing to increase.
Okay, now I'm going to ask a direct question of you and Larry. What is your recommendation? You're right in the weeds. Are you recommending that we terminate, or you just kind of want us, I mean,
All right, my recommendation would be to terminate. We can go ahead and go the other route. If you want to put the resources in and hire staff, we'll do that. But knowing what we know today, and that's the only thing I can tell you, looking at the stuff that we look at the last 18 months, my understanding and talking to staff is that not only would we have to add staff now, but probably for every 6 months, continued growth. Am I correct on that?
So we took a 12-month look back at 2020 when we put this together, and you get a net average of 10 new members per month and approximately 2 are termed for a variety of reasons. So that's a net of 8. When I looked at these positions, I feel their caseload size would have to be at 50 or below in order to be able to do min choices, do the larger time volume, shorter deadlines to complete their work, because min choices is electronic. If you have to do the assessment, close it, to get your screening doc, to move to your CSSP, and then your CSSP, to get your services to the senior. Now they can do this, and then they can do their paperwork a little later with paper. You can't do that with electronic because there's a sequence where it closes you down after a set period of time, or you have to close down your next function to get to the next step. So 50 was mine. So again, take 8 times the number of months, you're looking at between 6 and 7 months if the number of new, on average, members increase. And this last month was a large month. So that's, again, whatever decision you make, my role as a supervisor is to bring forward when I see I can't get the job done the way we should for our members, our providers, and for the county. And that was what I was looking at.
So based on that information, that's how we made our decision to make a recommendation. We're good going either way. But again, as you know, our job is to come with what we believe is the best option at this time.
So what it feels like to me is that we have a staffing issue. If we continue doing this, we're gonna have to add staff. And so it's either gonna be our issue or we can let it be Blue Cross Blue Shield's issue.
Correct.
And given given the current state of affairs of staffing, I think I know where I would, who I would let have that headache. Commissioner Gardner.
Thank you, Mr. Chair. Jenny, I think I understand you to say that if we keep the contract, we're still going to have to add staff and supervisory capacity.
That is correct.
Okay.
And I want to say again, it would be staff in all of our areas of the home and community-based services. So that's going to be our mandated services areas, waivers and min choices, along with this contracted service that we're doing of care coordination.
And to Commissioner Nissen's point, then this is really where the budgetary impact would lie, correct? Okay.
Commissioner Berg.
I feel like we're almost in a catch-22 situation. And none of the board wants to add to government and make government bigger. But I look at it from the point of view that unfortunately counties are at the bottom of the food chain in the sense that the federal and the state government, passes all these mandated services and not saying they're wrong or bad or whatever, but they come down to us and we have to buy these services and figure out a way to do it. And unfortunately, we do have to have staff at times. I'm feeling a little bit better about this. Hope the perception across the county will be okay. On the surface, it looks like we're talking about adding 3 to 5 staff or even actually 7 staff, but reassigning some of the people, and we had them already. Just looking at, besides this, you're looking at probably another supervisor, another higher up position as well. 2 more positions. So I worry for planning county-wide for staff needs because other departments are really hurting as well. And they want staff. So, where do we draw the line? But it sounds like this is very important and the needs are there. I think we have to just move forward on that. And we have not added many staff. I understand we've been on the board for 2.5 years now. But I understand we haven't added many staff over the years. And we were shuffling this. It looks like it might be workable. I am still worried though about the clients. So Blue Cross Blue Shield, they're going to come into the community and contract with some private agency to do the service. Am I correct?
Yes. So they would start trying to get somebody else to take this contract, a different entity.
And if they can't find anybody, or what happens then?
I have no idea.
Is there a chance?
I don't know.
I guess I'm kind of going with this too. Is there a chance they may come back to us with a better offer?
I don't know that. Again, I've been very straightforward. We've been talking to them for now over 2 months probably in just conversations, and they haven't once said anything, and they've known that this has been in front of you last meeting and now this meeting, so.
Commissioner Gardner.
Thank you, Mr. Chair. I will offer a motion to terminate the Blue Cross Blue Shield Care Coordination contract.
So we have a motion on the floor to terminate the contract with Blue Cross Blue Shield. Do I hear a second?
I'll second that.
Commissioner Anderson seconds. Any discussion, further discussion? I would just say that, there's a couple of things that we have to face, to Commissioner Berg's point about rising costs to provide services to our citizens, to our clients, is that we can't forget the aging population. I mean, right now, we're exactly in the middle of the baby boom, turning 65 years old, and that's a huge boom or chunk of population for the next 9 years before that starts to diminish some. And the numbers just speak for themselves. You just cannot change that. And so increased services, increased costs are a fact of life. Commissioner Gardner?
Thank you, Mr. Chair. I think we also know that if there are changes today, there will be changes tomorrow. And we don't know what those impacts are going to be. We can only make this decision in this particular moment in time, and then we'll deal with whatever comes out of that.
Any other comments or questions? If not, I'll call for the question. All in favor of the motion signify by saying aye.
Aye.
Opposed, same sign. Motion carries. Thank you very much.
Thank you.
And leaves us enough time for a quick amount of information regarding a contract, Corinne. Maybe, I don't know how long your
Really
report
fast.
is. Maybe we'll just do the contract for today and
Okay, let me think about that, because we're making a change in this contract, and I was going to try to explain where we've been, where we're at, where we're going to, and that'll make more sense about what we're doing with the contract, so I'll try to just condense that, okay? On what this, the area that I'm talking about is our substance use area, or our chemical dependency, as it's been called in the past. And just to kind of briefly do an overview of kind of where we were, where we're at, and where we're going to. The substance use area is under a major reform in the state of Minnesota. And what used to be of how we did business was what we called Rule 25 and Rule 24. What that is, Rule 25 is an assessment that is done with clients. The clients that the county had responsibility for were clients who were on medical assistance or not having any funding source for substance use treatment or any sort of service along that line. And so what a person in that type of a consumer would need to come to the county, request a Rule 25 assessment. And the county has that responsibility, still does, has that responsibility to do that assessment and then be able to make, taking the recommendations of that assessment and be what we call the placing authority, meaning we could assist that client in getting into treatment, meaning whatever those treatment needs may be, whether that's an outpatient situation or an inpatient situation. What's happened with reform is it's really looking at moving on chemical dependency or substance abuse away from that kind of acute situation and moving it really into what it is, which is really a chronic situation, an illness, and being able to look at how do we deal with that and how do we move away from making it just be this acute sort of process or model, if you will. So for 30 years, that process was Rule 25s. Person come in, get that assessment. Then if they didn't have any funding source, we would use the Rule 24, which is like the funding piece of the Rule 25s. And the Consolidated Treatment Fund would pay for those services, they would pay for the treatment, those sort of things. Now what the switch is, and which the reform is really moving into taking the county out of that mix. And so what that is that instead of, if I'm a consumer, I'm in need and I'm on medical assistance or I have no funding source, I don't have to come to the county. I can go to a provider and be able to have that provider do that assessment, that provider to make that recommendations and then work with me to be able to get me to whatever level of services I might need based on that comprehensive assessment. So we're in a process where it was all Rule 25, it's all you had to come to the county, and then now we're slowly moving to where it's what they call the direct access, which is where a person can go directly to the provider, or the person could still come and request a Rule 25. So we're slowly moving in the process to where Rule 25 will totally go away. So come on July 1st of 2022, Rule 25 won't be in the mix anymore. It will all be what we call direct access. Clients are going to need to go to the provider directly. It's very similar to mental health. If I am needing therapy, if I'm needing a diagnostic assessment, if I'm looking for any level of mental health services, I don't have to come to the county in order to get that. I can go to directly to the provider, and the provider can assess me and work with me on what type of services are needed based on that assessment. So it's really moving on the county out of the kind of the middleman, getting rid of the middleman for those clients that have medical assistance or those clients that don't have a payment source. And the major change why we're able to do that is because now comprehensive assessments, or what we would call our Rule 25 assessments, are now billable to medical assistance. So a consumer can go to the provider can bill out directly for that assessment. Now, if it's someone who doesn't have a funding source, the provider then is going to connect with us at the county level, who then need to determine if that client is income eligible to be able to do what they now are calling behavioral health fund. which in the past was called the Consolidated Treatment Fund. And so there's still a role that the county is going to have as it relates to approving the funding for someone who doesn't have any funding. But that is taking us out of the mix of the assessments. It's just really being that ability to approve the funding. So the client still goes to the provider. The provider realizes in working with the client they don't have a funding source. They connect with the provider then is connecting with the county. The county assesses it to see if they're income eligible, and then we approve that. It's what's called the 00 span. So we're putting it into the system, and then the provider is going to be able to bill out for that. So I'm kind of doing this in sort of a nutshell. And so as we move forward, the goal is that direct access will be totally what happens. That the clients are going directly to the provider. The county will be totally out of that. If we choose to be, we'll be totally out of the comprehensive assessment. The assessment, the Rule 25 will go away. There are some added services, and I think we can probably talk about that more at a different time. But with that in mind, it goes to our contract that we need to approve today or discuss today. What Candioi County has done for a number of years is that we have contracted out our Rule 25 assessments. And we have contracted with 3 different providers. The provider that I have in front of us today is Project Turnabout. And what we have done with Project Turnabout for a number of years in our contract is we have given them a lump sum of money. And for that lump sum of money, they've provided us slots, is what we call it, on a calendar, so that when someone comes to us looking for assessment, we're able to get that initial information, we're able to plug them into an assessment time frame. And then we set that all up, and they go to the provider, and the provider does that assessment for us, and then we pay the provider that. With Project Turnabout, we've done it as a lump sum so that they assured us a certain amount of assessments a week. That allowed us to assure that we have our assessments done in 20 days. Once that request for an assessment is done, we're required to do it in 20 days. So having those slots available allowed for those assessments to get done. Our requirement, of meeting that 20 days happen. What we're looking to make a change on our Project Turnabout on contract is to move from that lump sum is to go down to an assessment rate. Because as our numbers are, as we're moving away from Rule 25, our numbers will be decreasing. We may or may not use much of this contract because of the direct access that's going to continue to keep happening. That billing and how we're able to bill out for those assessments is changing, so our need for paying directly for that assessment will be changing. So that's the change that's happened in this contract, is moving away from the lump sum and going down to an assessment rate. The rate that we are proposing is $164.24. That amount is based on what the provider is able to bill out for medical assistance, pays that rate, and so we're just matching that rate. That was really quick, so I don't know if there's questions.
Any questions? Go ahead.
No, I was just going to make a motion to approve the contract.
So we have a motion.
I'll second that.
To approve I caught Commissioner Gardner first, so. We have a motion and a second. Any discussion?
I just have a quick comment. It's been wanting to go, this whole system, go this direction for some time. I looked at the contract and went, what's this all about? It's a good move. I really, it's been a good presentation.
Thanks, Suze. And I would like to come back on, doing my annual report, that's part of what I was going to do, and substance use is one of those things. And I think I will just come next time when I'm doing my other ones, I'll just add some things about substance use that I think are important for us to pay attention to and understand some of the numbers that are in the annual report as well. And also just to say, this is just not a family service process. Community Corrections is involved in that as well. They've been a team throughout the years of doing the Rule 25s as well.
Well, thank you very much for that brief. And I apologize that
Oh, no,
your
that
time
is
got
fine.
cut a little short, but thank you again. We have not yet voted on this, so all in favor of the motion signify by saying aye.
Aye.
Opposed, same sign. Motion carries. Thank you very much.
All right, thank you.
I will adjourn the meeting of the Kaneohe County Health and Human Services.